Great to be here at ASCO GU 2019. I've had the pleasure of working with a lot of fantastic Latin American colleagues. It's been a pleasure to have Manuel Caetano Maya over at City of Hope for a year-long fellowship. I'm currently working with Paolo Bergero and Chris Bergero, two outstanding medical oncologists and psychologists respectively, and also Dr. Steny Ezeki at AC Camargo. Lots of great partners down there. A lot of things that I'm excited about at this meeting. I think for kidney cancer, it's been a huge year. I would tell you that the biggest advance at this meeting is going to be Keynote 426. This is a trial that looks at a comparison of sunitinib as standard of care versus the combination of axitinib with pembrolizumab. Tremendous survival advantage there, hazard ratio 0.53. This is a key advance. I think that it's going to be important for us to start thinking about where to, for instance, apply VEGF plus IO versus IO plus IO in the context of newly diagnosed metastatic disease. My personal opinion is that if you see a patient, for instance, with de novo metastatic disease or synchronous Mets, for instance, it probably makes a lot of sense to start with that approach of IO plus IO. It basically allows you to maybe proceed to cytoreductive nephrectomy if that's your intent. It's a little bit more complicated when you throw a VEGF inhibitor in the mix. On the other hand, I would say that for patients who have metastatic disease that is, for instance, asynchronous or comes on at a later time point, makes a lot of sense to consider combinations like axitinib with pembrolizumab. Now, that's primarily your intermediate and poorest patient population. For patients with good risk disease, I think the bar is very, very high. We have to keep in mind that these are patients that are going to live for a very long time. And in that subset of individuals, we really want to make sure that we do no harm. So for that reason, I consider that still to be fertile ground, for instance, for VEGF monotherapy. I, for instance, am supportive of using agents like cabozantinib in that setting. Maybe no formal testing in the context of good risk disease, but I have no reason to think that it's not the best VEGF TKI to get the job done. I look forward to seeing multiple data sets evolve in the coming years to address that question. And of course, sequencing questions really become paramount in this day and age. So that's my perspective on frontline therapy.